educational content by Dr. Mohammed Al-Nagi Mohammed. Hello and welcome. Today, we're going to break down the essential clinical framework for diagnosing type 2 diabetes. Look, whether you're seeing patients day to day or you're gearing up for your specialty exams, this is one of those high-yield topics you absolutely have to know inside and out. So let's get right into it. We've got this broken down into 5 clear parts. First, we'll look at the initial diagnostic pathways. Then, we'll get into the nitty-gritty of the numbers for both plasma glucose and HbA1c. After that, and this is super important, we'll cover the situations where HbA1c just isn't reliable. And finally, we'll wrap up by exploring the pre-diabetes spectrum. It's a really logical flow that takes you from that first patient encounter all the way to a nuanced diagnosis. All right, first up, the initial diagnostic pathways. The most important thing to grasp right at the start is that our approach isn't a one-size-fits-all deal. It really all hinges on one simple question. Does the patient have symptoms or not? And this slide lays out that distinction perfectly. If your patient shows up with classic symptoms, the polyuria and polydipsia, then a single positive test is enough. Diagnosis confirmed. But if the patient is asymptomatic, maybe you just picked this up on a routine screening, you absolutely need 2 separate positive tests to make that call. This is such a vital principle to prevent a premature diagnosis, and trust me, it's a very common exam question. Okay, so we know the pathways, now let's talk numbers. This brings us to section 2, which covers the foundational method for diagnosis, the plasma glucose criteria. These are the classic thresholds that we all just need to have locked in.
So let's really focus in here. What are those key plasma glucose numbers that we need at our fingertips?
The first key number you need to know is 7.0 millimoles per liter. A fasting plasma glucose of 7.0 or greater, that's a diagnosis of diabetes. And the second number is 11.1 millimoles per liter, a random plasma glucose. Or the 2-hour value after a 75-gram oral glucose tolerance test, that's 11.1 or higher, is also diagnostic. Now, just a quick clinical point here. The distinction is pretty straightforward, but important. For a fasting sample, the patient needs to have had no caloric intake for at least 8 hours. A random glucose, on the other hand, can be taken anytime, which makes it convenient, but you have to remember it can be influenced by a recent meal. Just keeping that context in mind is key when you're interpreting the results.
Right, let's move on to our other major diagnostic tool. Section 3, HbA1c diagnostic thresholds. This test is fantastic because it gives us a window into the last 2 to 3 months of a patient's glycemic control. It's really become a cornerstone of how we diagnose diabetes today.
And the magic number for HbA1c is 48 millimoles per mole. That's the same as 6.5%. If you get an HbA1c at or above this level, that's diagnostic of diabetes mellitus. But remember, just like with an asymptomatic glucose test, if your patient has no symptoms, you need to repeat this test to confirm.
Now, this is such a critical point. A normal HbA1c doesn't automatically mean you can rule out diabetes, especially if you have a high clinical suspicion. Why? Because plasma glucose testing is just more sensitive. So if you have a patient with clear symptoms, but their HbA1c comes back normal, you have to follow up with a plasma glucose test.
This brings us to a section that is incredibly high yield, especially for anyone studying for the MRCGP AKT exam. When is the HbA1c unreliable? Knowing these exceptions isn't just for exams, it's absolutely essential for safe clinical practice. So here's the list. Basically, any condition that messes with red blood cell turnover is going to skew the HbA1c. So that means things like hemoglobinopathies or hemolytic anemia. It's also no good in cases of untreated iron deficiency, for kids, during pregnancy, or in patients with HIV or chronic kidney disease. And you also have to consider medications that cause hyperglycemia like corticosteroids. The take-home message for all of these situations is simple. You have to fall back on plasma glucose for your diagnosis. And finally, let's look at that crucial gray area that sits just before a formal diagnosis. Section 5 is all about the pre-diabetes spectrum. This is where we identify those at-risk states, impaired fasting glucose, or IFG, and impaired glucose tolerance, or IGT. First up is impaired fasting glucose, IFG. This is defined by a very specific narrow range. It's a fasting glucose that's 6.1 or higher, but it's still below that diabetic threshold of 7.0. Next, we have impaired glucose tolerance, or IGT. The big difference here is that you can only diagnose IGT with an oral glucose tolerance test.
So the patient's fasting glucose will be below 7.0, but their 2-hour number after the glucose drink falls between 7.8 and that diabetic cutoff of 11.1.
This table really sums up the difference nicely. You can see IFG is all about that fasting glucose, right there in the 6.1 to 6.9 range. IGT, however, is all about how the body responds to that glucose challenge. And it's important to know, a patient can have one, the other, or even both.
So, what do you do with this information in practice? Well, this guideline from Diabetes UK is key. If you discover a patient has impaired fasting glucose, the recommendation is to offer them an OGTT. This does two things. One, it helps you definitively rule out overt diabetes, and two, it lets you check if they also have impaired glucose tolerance at the same time.
And this all brings us to our final and perhaps most important question. We've just walked through the entire diagnostic framework for both diabetes and prediabetes. But let's be honest, the diagnosis is just the starting line. The real question is, how does identifying these at-risk states early actually change what we do, how we manage these patients, and ultimately, does it improve their long-term outcomes? That's really the critical next step in our thinking.